Good afternoon. It is a pleasure to be with each of you for Little Rock Know Your Facts COVID-19 Town Hall, moderated by the famous, intelligent, elegant Donna Terrell of FOX16.
Thank you.
Before we carry on, I want to make a few comments today. As we all know, on March 12, 2020, all of our lives here in Little Rock changed. That's the date that we started our state of emergency for the city of Little Rock and how we navigated through COVID-19. We now sit here today on February 3rd, 2021, and we're still in the midst of a pandemic. We're happy that we have pushed through the pandemic of 2020 to see the year 2021. But we are ever more vigilant now as we focus on not only COVID-19 testing and wearing our mask and watching our distance and washing our hands. It's about knowing the facts of the vaccine. And so one of the things that we were able to do was to carry on and learn more about COVID-19 when we instituted Little Rock's COVID-19 task force that's chaired by at-large city director, Dr. Dean Compuris. We're grateful for his leadership as well as the members of the medical community that have been advising me and my administration on how we navigate through this pandemic. Now, as we're transitioning from while remaining focused on our mask and remaining focused on the 3 W's of watching your distance and wearing a mask, we also have to focus on how do we continue to have more individuals access to the vaccine and to take the vaccine. We clearly know there are a number of different challenges, particularly with communities of color, Black and brown residents here in Little Rock. And so we are happy to have this partnership with the Little Rock chapter of the Links, which is a storied and historic organization of esteemed Black women. And we are grateful that they are partnering with the city of Little Rock to educate and to engage the community. So thank you to the esteemed women of the Little Rock chapter of the Links Incorporated for this partnership today. And as we have this partnership, clearly I'm not a doctor, but we have doctors here with us today. We have Drs. Jennifer Dillahay, Dr. Sam Greenfield. We also have Dr. Akilah Jefferson and Dr. Case Juarez, who are with us today from many medical institutions, whether it's Arkansas Department of Health, Arkansas Children's Hospital, University of Arkansas Medical Sciences, who are all playing a role in advancing our knowledge, not only for all residents, but also where there are healthcare disparities. We know there's great mistrust when it comes to the Black community in healthcare. Some, if you don't know, take time to learn about Tuskegee Airmen, but also the likes of Henrietta Lacks and the HeLa cells, where there's been certain things that have happened over the course of time that has caused African Americans and Blacks to have some mistrust with the healthcare. Well, take this time to listen to these experts, to understand the data and the research, things that weren't done in years past. There's been a considerable amount of work that has been done. These doctors, these esteemed Little Rock doctors, these doctors will share the information so we all know the facts as it relates to not only COVID-19, but the vaccinations, whether it's Pfizer, Moderna, and forthcoming Johnson & Johnson. So I'm grateful for each doctor that's taken the time out of their schedule to utilize their God-given talents to educate the people of Little Rock on why we should take the vaccine and how it prepares us for a post-COVID-19 era here in the city of Little Rock. So again, I want to say thank you to everyone, from Dr. Compuris and every member of the Little Rock COVID-19 task force, to Donna Terrell, who's going to be serving as our moderator, and as well as all of the doctors. Donna, you have it from here.
All right, Mayor Scott, thank you so much. And thank the city of Little Rock for having this important discussion. You mentioned the Little Rock chapter of the Links Incorporated. As being a co-host of this event, I'm a proud member. So I echo your sentiments. And I also want to thank our viewers who tuned in today. And just so you know, we've received a lot of questions from you. Thank you so much for that. We're going to try to get to as many of those questions as we can. And if you did not get a chance to submit a question, you can do so in the comments section of the live stream of the City of Little Rock's Facebook page. As you've already heard, this town hall is to provide some clarity so that we can all start to work together to get rid of the spread of COVID. So I want to get started, and the mayor has already introduced our esteemed doctors, but I will introduce them once again quickly, and as I introduce your name, please give brief remarks. Dr. Jennifer Dillahay is the state epidemiologist at the Arkansas Department of Health. Dr. Dillahay.
Well, good afternoon. It's been a pleasure to be part of this group, and my remarks have to do with my role. I serve as the state epidemiologist, so I play a leading role in how we address this pandemic in Arkansas. Anything that we can do to reduce the spread and provide vaccines and make sure everyone is protected. That's my role here.
Okay, thank you. Dr. William Sam Greenfield is an obstetrician gynecologist at UAMS.
Good afternoon. Thank you for the opportunity. A year ago, we learned of COVID and began to track it in Arkansas, and a year later, we're looking at nearly 300,000 cases and 5,000 deaths. It's disrupted our families. It's disrupted our lives. It's separated families at the time of birth. It's separated families at the time of death. And we are at a time now where we have options for treatment, for vaccinations that we didn't have. And while we're still in the middle of this crisis, I think it is imperative that everyone gain the information that they need to make the right decision. I strongly encourage people to get the vaccine. And I hope through this town hall, folks will get the information that they need. And trust me, I'm a native from Alabama. I grew up hearing about Tuskegee. I lived in Mobile, so my folks from Mobile called me when Hank Aaron passed and said, what's going on? So I understand the trust and the anxiety that people may have as they go through this. But I hope through this, we can put some myths to rest and we can answer the questions that you have. Thank you.
Thank you. Dr. Akila Jefferson is a pediatric allergist and immunologist at Arkansas Children's Hospital. Doctor.
Hi, thank you for having us here today. I'm very excited. I think my role here is really to talk a little bit about the data and the science and to help people understand there's been so much misinformation going out there with regards to COVID-19, with regards to vaccines, how they work, how they don't work. As an allergist and immunologist, I hope that I can shed some light on that. As a pediatric allergist and immunologist, I hope that I can help people understand better what's happening in that community as well. And then also as someone who really studies health disparities and all of the issues that have happened in the past and the present with regards to communities of color, I hope that we can also shed light on that and have a very good conversation about reasons why the vaccines are safe and why you should consider taking them.
Dr. Kayer Bias is an infectious disease specialist at UAMS. Thanks for being here.
Thank you, Ms. Terrell, and thank you, Mayor Scott, for your leadership and for the opportunity. As each of our panelists have mentioned, as Dr. Greenfield elaborated, this past year has been unprecedented with challenges for our city and state and really the entire world. And it really feels like we've been playing defense for the last 11 months. We've been doing things to try and protect ourselves and our families and everybody around us. But there is light at the end of this tunnel, and with the vaccines coming around, there is an opportunity to get ahead of the virus and to really begin to protect people on another level. And I'm really thankful for the opportunity to participate today, thankful for the ability to work with such esteemed colleagues, and really have been thankful for the opportunity this past year to work with our colleagues across the state to try and minimize the spread of this virus as much as possible to be able to get to this point. As an infectious disease physician, I've certainly seen what this virus can do and the devastation that it can cause. and we really need to do everything we can to put it behind us. And that starts with certainly doing all the things that we have been doing up to this point, masking, distancing, but now also taking the vaccine when it's our turn to do so.
Okay, thank you, Dr. Bias. Before I throw out the first question, I think it's important to establish that the vaccines are being distributed in the state of Arkansas. So we have a graphic that we want to put up so that you can see what phase we're in and get a better understanding. I think that graphic should be going up any minute now, but we're in phase 1B, which started on January 18th. It's for people 70 years old or older, teachers and school staff, child care and higher education workers, food and agricultural workers, firefighters, police, correctional staff, manufacturing workers, grocery store workers, public transit, the U.S. Postal Service workers, and essential government workers as well. Many people are wondering, when will it be my turn? As it stands right now, it looks like it'll be closer to the beginning of April. In terms of the vaccines that have been given thus far, the state of Arkansas has received over 486,000 doses of the vaccine. 301,000, just over that amount, has been given out so far. That's 61.9%. And what I find interesting is the CVS Walgreens program that is supposed to administer the vaccine to folks in long-term care facilities. They have been allotted more than 49,000 doses. Only 17,000 have been given so far. That's just 34.6%. Questions as to why that's happening. I know a lot of people in the community, they don't want to get this vaccine, or they are afraid to get it. Some people are afraid of the side effects. They've heard all sorts of stories about this. One of the things we want to do right here, right now, is bust some of those myths. So let's get started. Number one, mistrust in government. The vaccine is too new. The vaccine was just developed, and it was centered around politics. That is preventing a lot of people from wanting to take this vaccine. So I guess, Dr. Dillahay, I'm going to start, since you're with the Arkansas Department of Health, I'm going to put you on the spot with that question. How would you address that issue where people, they just don't trust the government? The vaccine is too new. They don't feel it's safe.
So these are the first two vaccines we've had using the RNA vaccines. But these vaccines have been studied and under development for decades. And it just happens that these are the first two. And when these studies were done to establish their safety and whether they work or not, they were done in the same way. All the steps were taken that we do other vaccines, but we were able to do them quickly because the funding enabled the government to work with the manufacturers so that they could do all the steps. Instead of doing them sequentially, they could do some of them overlapping at the same time. Plus, they funded the development of the vaccines in such a way that the drug companies made doses in advance before they were authorized for use. And that's something under normal circumstances a pharmaceutical company would never do. They would never make millions of doses before the vaccine was allowed by the FDA for use. But they did in this case so that doses would be immediately available once it was authorized by the FDA. So go ahead.
I think one of my questions in there, just to follow up on that, is with that, I think the knowledge that most of us have is that in terms of the participants in the study, we don't know beyond a few months what this vaccine will actually do to a person, or how long it will even protect a person. Or do we?
So that's always the case with the new vaccine, is to study the long-term immunity for it. But we know from other vaccines that it only takes a couple of months to identify the common side effects. And that was done in this case. Now, there are rare side effects that will never be identified in the clinical trials because you would need to have many times more people enrolled. So say a clinical trial has 50,000 people in it. Well, if you have a rare side effect that occurs 1 out of every 100 or 2,000 people, you might not see that in the clinical trial, but once it's out in use, you may see that. And for those reasons, we have very well-developed mechanisms or systems in place to detect those adverse events. One of them is called the VAERS, the Vaccine Adverse Event Reporting System, and anyone can report to that. So that if something like that appears, in the case of these vaccines, the severe allergic reactions, some have occurred, and there's ways of reporting that to identify it as a potential problem.
Okay, Dr. Dillahay, thank you. One of the things I really want to dive into, and I wanted to do this early on, is talk about African Americans and their fear of this vaccine. And many of you have mentioned, the Tuskegee study, and many African Americans don't trust the healthcare system. And then on top of everything, Hank Aaron takes the vaccine, and then 2 weeks later, he dies in his sleep. We've seen it on social media. A lot of people are saying the vaccine killed him. So, Dr. Jefferson, can you address that? What would you say to someone who says, I'm just not going to do it. I'm not taking it. It killed Hank Aaron.
So, there are a few things to unpack there. The first is that I think, I understand why people are hesitant, why they are scared. It's a scary situation, right? We are in the middle of a pandemic. We've not had a good time with this at all. We've all lost loved ones. We've seen the devastation. It's a very scary time, but I think we all need to focus on the information that we do have, the data that we do have on the safety and the efficacy of the vaccines, both of which are very good. So efficacy-wise, we know the vaccines are between 94 and 95% efficacious. Safety-wise, they're very safe in the clinical trials. And since we've had millions of Americans vaccinated since December, we're also seeing that the vaccines are very safe. Hank Aaron, wonderful baseball player, Hall of Famer. There are plenty of people who, horribly enough, pass away for various reasons, natural causes. He had an autopsy done. The medical examiner is saying it is natural causes that caused his untimely death. He was also very elderly and had other underlying health conditions that have nothing to do with the vaccine, with COVID-19 or anything like that. So I think really reminding people that, just because he had a vaccine and passed away a few weeks later does not mean that the two events are related in any way, shape, or form. And focusing on that and the safety data that we do have, which also makes us very confident in the safety of these vaccines for the vast majority of the population.
Okay. Dr. Greenfield, some women are afraid that this vaccine, this is another myth, could have an effect on their fertility.
Right. So, for one thing, pregnant women were not included in the trials of this vaccine. And there's been no evidence to show that it would have an impact on fertility. Now, we are still gaining more information, but there's nothing in this from the vaccines that we have in our use right now to suggest or support that they would cause problems with fertility. And for women who do become pregnant, while pregnant women were not included in the studies, the risk of contracting COVID, the risk of disease, should seriously be considered as one makes a decision as to whether or not they would receive the vaccine. Our societies, the American College of Obstetricians and Gynecologists, encourages in the future that pregnant women do be included in the studies. But in the present time, it is certainly something that they should have a conversation with their physician if they have additional questions. But the vaccine should not be withheld from pregnant women. And I think you have to assess what your personal risk is. If you're a healthcare worker, if you're in an environment where the risk of contracting COVID is real, as it is for all of us, but If it's especially increased based on your work, then that would be a factor to consider. So I would say that having the vaccine in terms of impact on fertility, there's no evidence to suggest that. And if you're pregnant, then I would encourage strong consideration to getting the vaccine and getting more information if you need it by having a conversation with your healthcare provider.
Okay. Dr. Vyas, can the vaccine actually give you COVID-19?
No, both current vaccines that are available through the emergency use authorization, the Pfizer and the Mrna, they do not contain actual virus particles. These are, as Dr. Dillahay mentioned, these are mRNA vaccines. They contain a piece of RNA that gives instruction to our own cells to make a protein. Now, every cell in our body makes proteins every second of every day. These instructions make the protein that's on the surface of the coronavirus, and that's what our immune system recognizes. The vaccine doesn't include the virus at all, doesn't include the ability to make a whole virus. So we make just this one piece. The cell makes the piece, and that's what our immune system recognizes. So in effect, we teach our immune system to recognize this one piece of the virus so that when it encounters the full virus, it knows how to fight it off and prevent people from becoming sick. So the two vaccines have no way of transmitting the virus. And actually, the other two vaccines that are up on deck for evaluation, the Johnson & Johnson, which is a little bit different technology. It's an adenovirus, which is a completely different virus that has been engineered, and it cannot transmit the infection as well. And then the other one that's next is the Novavax, which is also a piece of protein. So none of the vaccines that are being tested have the actual coronavirus in it to be able to transmit.
Okay, Dr. Dillahay, what about your DNA? There's another myth that if you take this vaccine, it could alter your DNA.
There's really no biological reason how that could be possible. The mRNA goes into the cell, as Dr. Vyas said, and it makes that protein. But then the mRNA gets degraded very quickly. It never goes into the nucleus of the cell where our DNA is. It's just biologically impossible for these vaccines to alter our DNA.
Okay, all right. Well, I wanted to get through those myths because there are so many of them floating out there, and certainly I'm sure there are plenty more of them, but thank you for your answers on that. One of the things I've been trying to figure out, and I thought more about it today, herd immunity. I keep hearing people talk about this herd immunity. You know, we need to take the vaccine for that, to reach that point. Explain what that actually means and how herd immunity protects all of us. I could call on one of you, Dr. Greenfield.
I'll start. Maybe Dr. Vyas can add to it.
Okay.
So herd immunity is when you have enough people in the community. So some people call it community immunity. But enough people in the community have protection either through a vaccine or having had the disease itself to keep the virus from circulating because there's not enough susceptible people around to keep it going. So that's what we're talking about.
That makes perfect sense. So let me then ask you as a follow-up, and Dr. Vyas, you can follow up on this. If does it matter in that case if, you know, like we know that the two that are available right now, Moderna and Pfizer, are 95 and 94% effective. There's another one coming on the market, maybe more like 65% effective. Should anyone be concerned that, oh, I'd rather take this vaccine as opposed to that vaccine because this one says it's more effective, and then they miss an opportunity to take the vaccine?
So I can start. The short answer is that no, people shouldn't try to pick which vaccine they get. One thing to remember is that the vaccines are a little bit different. There's different technologies, and they were also studied in different ways. And so both Moderna and Pfizer are 2-dose vaccines. You get a shot and then either 3 weeks or 4 weeks later, you get a second booster. The Johnson & Johnson vaccine is a single-dose vaccine. And so that 66%, that's looking at all comers across 3 continents. So in Africa, South America, and North America. And really also looking at the South Africa variant, which had a little bit decreased efficacy. In the US, the Johnson & Johnson efficacy, from what we have available, and we don't have the full data available, we hope to have it out when they apply for the FDA within the next week or two. But the efficacy in the US was more on the order of 72%. And they're actually doing another study where they use 2 doses. Now, one thing to keep in mind is the vaccine that's doing the best good is the one that's in somebody's arm. And I think from the thing to remember with all of these vaccines, the 4 that we've talked about so far, and as well as the AstraZeneca one, which is available in Europe, there have been looking at the studies, there have been over 75,000 people that have gotten those in the trials. And the biggest marker was the development of hospitalization, death, severe disease. And all of these vaccines were phenomenally protective against that. So we see that with other vaccines, that even if the efficacy is not 90+%, that they do help prevent people from becoming severely ill, ending up in the hospital, or God forbid, dying from it. And so a vaccine like the Johnson & Johnson one, which is 66%, taking all comers, is actually, not a bad thing. And I think that we have to be careful that just because the first 2 that came out had these phenomenal numbers, we don't lose sight of the fact that a single-dose vaccine that is easier to administer because it doesn't require the cold storage that the other ones do, that it can do a lot of good to make sure that we get closer to that goal of herd immunity. It's much better to have more people vaccinated, and that makes it much harder for the virus to spread and continue.
Okay. Dr. Jefferson, can you help me understand in terms of children? I think I heard somewhere that you had to be 16 or older to get this vaccine. Why can't we vaccinate children who are obviously susceptible to getting the virus? And why is there a cutoff in terms of the age?
Right. So the main reason is because the studies were done in people that age group. So for the Pfizer vaccine, 16 and up, and for the Mrna vaccine, 18 years and up. Currently, they still have studies that are ongoing for both Pfizer and Mrna going down to age 12. And then the hope is that we can go down even to lower age groups after that. But generally speaking, for clinical trials, for new medications and new vaccines, we always test adults first, and then we go on to children after that. So this is not unusual from that standpoint. It's just the way that we do trials to make sure things are safe, they're efficacious, and then we test them on kids, which is the place where we are right now. But still, for those kids 16 and up for Pfizer, it is technically approved. For kids who have underlying health conditions, per some of the phases, they go a little bit higher than kids who are completely healthy. But you're right that we hope in the future that we can get kids vaccinated. In the meantime, we get kids, parents vaccinated, teachers vaccinated, other people who are in contact, so that we can really reach that herd immunity that we keep talking about.
Okay. We're getting quite a few questions that are coming in, and some that we've already had. I'm going to get into our viewer questions now. So bear with me here as I read through some of these. And this is really important, though, because I know a lot of the pharmacies, from what we hear, end up with excess doses, and some of those doses end up up getting thrown away. Someone is asking the question, I don't know if you have the answer to this, how many doses have been thrown away because of people not wanting them, or because, I guess it would be because people didn't show up for their scheduled appointment to get the vaccine. Is that happening a lot right now? Dr. Dillahay?
So actually, we've had extremely few wasted doses, and the ones I'm aware of had to do with either a broken vial or improper temperature. But so our pharmacies that have these extra doses, they have waiting lists so they can call someone in. So it's important to know that for the Pfizer vaccine, there's 6 doses in a vial, and once you puncture the vial with the needle for the first time, you have to use all those doses within 6 hours. And for the Mrna vaccine, it has 10 doses, and you have to use them all within 10 hours. But people are not throwing them out because they can't find people. There is an abundance of demand out there for them, and places have people on call to come in at a moment's notice in case that they have an extra dose left over that they need to use. And very few have been wasted.
You know, I got a message from someone. Was someone about to speak? I'm sorry, I don't want to cut you off. Okay. I got a message from someone who said their mother lives at Good Shepherd. She's in the independent living. She's 85 years old. A pharmacy came there and said, we want you, anyone who wants to take this vaccine, go ahead and sign up. To date, this is an 85-year-old woman who has no idea when they're coming to give her the vaccine. We're already in 1B in terms of the group. So I'm wondering, certainly this is happening. This is real. And where is the breakdown here?
So actually, this is part of the current 1B. So 1B is for people who are 70 years of age and older. So independent living is not the same as long-term care. We vaccinated all the long-term care facilities in 1A. Now in 1B, people who live in independent living centers can get vaccinated if they're 70 and older. So this person would be eligible, and we're working closely with pharmacies to plan the availability. So they're making their plans already about when they'll come in and vaccinate. And then as vaccine is available, we're still receiving very few doses in Arkansas each week. We're making plans to systematically provide vaccine to those locations so that people in the independent living facilities and other facilities, areas around the state can get vaccinated. But it has to do with the fact that we receive very few doses. Maybe we receive about I think this week we got 43,000 new doses, and so that equates to about 573 doses per county, which is really clearly not enough to meet the demand.
It sounds like it. You know, there are some people, we got a lot of people who wanted to know, why is it that this group that's getting vaccinated now is 70 plus, the age group 70 plus, why not 65 years and older, like many other states are doing, or even like the government suggested? Why is Arkansas deviating from that? And any of you can answer that if you're able to. But Dr. Dillahay, go ahead.
Okay. So the Arkansas Department of Health is following the recommendations by the Advisory Committee on Immunization Practices. So they recommended 75 and older for 1B. And we adapted it for Arkansas, 70 and older. If we lowered the age group to 65 and older, we wouldn't be able to vaccinate people any faster. That would simply create greater demand, greater competition for the limited number of vaccine doses that we have available. So we have chosen to focus on the little older age group, but still lower than what was originally recommended, so that we can vaccinate the most vulnerable age groups in Arkansas, which for now is 70 plus. We wouldn't be able to vaccinate people faster by lowering the age group. We don't, it won't make us get vaccine faster.
It won't come any faster. Kim Martin, she has a question from Facebook. And Dr. Jefferson, you mentioned the vaccines are safe for the vast majority. Can you please speak to for whom the vaccine might be risky, not safe for?
Absolutely. So right now, CDC has guidance for people with a history of severe allergies to any components of these particular vaccines, including something called polyethylene glycol. And for those people, which is a very rare allergy to have and very rare to have a severe allergy to that, but for those people, they should not get the Pfizer or Mrna vaccines per CDC guidance. That ingredient is not in the, I don't believe it's in the Johnson & Johnson vaccine. And, you know, as more vaccines are coming out, we'll have to look closely at those components, which are we call inactive ingredients, to see if they have any potential for allergies in certain groups of people. I will like to say, though, allergic reactions in general to these vaccines is very, very rare. So the CDC just came out with a report last week, an update. They are reporting about 71 cases of severe allergic reaction out of about 17.5 million doses of vaccines. So this is not something that happens a lot. It's something people should be aware of and that we're looking at, but it should not, you know, it's not a big thing that's happening across the populations.
Dr. Greenfield, what I find very, very interesting, Dr. Jefferson talks about side effects. You know, someone very, very close to me, after he got his second dose of the Pfizer vaccine, he had an allergic reaction. He broke out in hives. And every time I tell someone that story, their first response is, oh, that's how they respond to that. People are really afraid of these side effects. What do you say to them?
Well, one thing you have to consider is when you see some of these effects, the redness, the swelling, this is a sign of an immune reaction, which is one of the things that you want. That's what you want. That is what we're going for. So I think it's important that people understand that when you have an immune reaction, there will be redness, there will be swelling, that may occur. But that is not the same as an anaphylactic reaction. That is not the same, and it should not prevent someone from getting a vaccine. I think the point to take home is that a lot of these questions you really need to ask, you need to get this information now so that when your time in the queue comes, you can actually go and make a decision, not to start thinking about it then. So the fact that someone had that reaction when you mentioned that, that's not alarming, because it gives us a time to answer the question, to put that concern to rest, so that when their time comes to make the decision as to whether or not they will receive the vaccine, they will be at peace with their decision.
Dr. Bias, you had a follow-up question or a follow-up answer?
Yes, and I'd like to point out, you know, I agree completely with what Dr. Jefferson and Dr. Greenfield said. But sometimes it can be hard to think in terms of the probability or percentages when we hear, you know, 71 people that had an allergic reaction. But we do have to put that in perspective with, you know, the risk. And so out of 17 million, and now we're over 26 million doses of the vaccine that have been given just in this country alone. And so this is a very safe vaccine. And if we look at other vaccines that we're used to getting on a yearly basis, in the case of the flu vaccine, this is not that much different from that. It's very close to the tetanus vaccine. I would wager that most of our viewers have had, you know, at least one, if not more, in their lifetime doses of the tetanus vaccine. And the number of people that are getting allergic reactions seems to be in the range of 2 to 6 per million people, which, again, you know, nobody wants to be in that range. But we have to keep in mind that, as we mentioned earlier, over 5,000 people just in our state, or almost 5,000 people just in our state, have died in the past year. So that's a risk of 1 in 600 of our fellow citizens in just in Arkansas have died of this. So the risk of the vaccine is orders of magnitude smaller than the risk of getting COVID and of dying of COVID.
You know, and I think you have a lot of people, though, who will say Yeah, but still, I'd rather take my chances getting COVID because they're seeing a lot of people get COVID, be out from work for however long it's going to take, and then they're right back at work and they're fine.
That may happen, but I would equate it to putting on a seatbelt after you've had a car wreck, okay? You can't get the vaccine once, you can receive it, but the protection is going to be optimal if you receive the vaccine prior to the infection. And so while we've had vulnerable populations and we think about the older population and the elderly being particularly vulnerable and succumbing to this disease, you also have to think about the person who is young and asymptomatic who unwittingly transmits it to their elderly parent, to their family member who may have a weakened immune system. So in so many ways, the vaccine offers an opportunity not only to protect us and protect our citizens in a way that is good for society and good for us all.
But let me just say this. If you get the vaccine, it does not mean you can't still get the virus or still transmit the virus.
So that is a question that's still being studied. The studies that were done were not designed to assess whether you could get the virus or transmit it. What they did show was that there was very high rates of protection for developing illness, which is really where the rubber meets the road. That's the first thing that we want. We want to keep people from getting sick, and we want to keep people from dying of this. If it does turn out that it does prevent acquiring the infection or transmitting it, that will be kind of the icing on the cake. But that's the reason that we still continue to advise people that they should continue to follow all of the preventative measures of masking, of distancing, because there is still that possibility that you may catch a different virus and be able to pass it on. So we have to continue to maintain our guard.
And I'm glad you brought that up, but it also takes us back to the issue of herd immunity and how by getting this virus and with the number of people who have getting the vaccine and with the number of people who've already had the virus and recovered, more of us will create an immunity to it. So if someone is infected by it, the likelihood of them spreading it to someone else who's protected, less likely to happen. I'm going to get to one of these questions on YouTube. There's actually two, but I'm going to combine them. Darcy Haygood, he's probably been waiting and waiting for me to get to this question. He says, my father works in the state tax office and has not been able to work from home. He is visited by the public. Doesn't he count as an essential worker? Why can't he get the vaccine? And this one, I really want to hear an answer on this because hairstylists are not in the group of essential workers. Why is that when they were one of the first entities that had to shut down? And so why wouldn't they be included? I don't understand that. I guess, Dr. Dillahay, that's going to go right back to you.
Okay. Well, we do have essential government workers in 1B. And so someone who works in the government in terms of tax and interfacing with the public will be able to get vaccinated in 1B. As soon, we don't have enough vaccine for everyone in 1B. So we've started out with the 70 years of age and older, and then people who work in the education sector. And when we get further along with that group, then we'll move on to another group. One reason that we have not included the cosmetology workers in 1B is because they have a way of protecting themselves. And it is not considered an essential job. Getting a haircut is not essential. We know that people who need to earn a living, of course, and so there are provisions for them to do that and to do so safely. So, but they have not been included as an essential worker.
Dr. Dillahay, I could hear all the stylists in Arkansas saying, what are you saying?
Right.
I guess that's just the way it is, huh?
We're following the ACIP recommendations, which is the Advisory Committee on Immunization Practices, and they did not include them.
I'm just going to say that to me is unfortunate because many of us, I mean, we may not have to go to a hairstylist or get our nails done, but folks are doing it. I went to get my nails done the other day, and the place was packed. So that's what I'm going to say about
totally
that.
understand that. Yeah.
Okay. Randall Naylor, he wants to know, and I think one of you already addressed this, but we'll just reiterate it. Will the mask mandate be lifted once herd immunity is reached? Actually, we have not answered that. Once we get to herd immunity, people want to know, when can I take off the mask? When can I go freely without people looking at me saying, why aren't you wearing your mask, or you can't come into this establishment without one? Any of you can answer that.
I'll say a few words. I like to use numbers to kind of describe what's going on. So right now across the United States, we'll say about 8% of people have been vaccinated. Estimates for what we need for herd immunity is somewhere upwards of about 70% of people to be vaccinated. So the short answer is we're not going to take off masks anytime soon. We have to get to that number to even consider thinking about that kind of stuff. The other thing is, I think, we have to think kind of step by step and be a little patient, although it has been a full year of being patient, which I also understand people are tired of it. But we will know things as the data comes out. So we can't preemptively say that we're going to know on, April that we can take off a mask. We need to see how many people get vaccinated, how that goes, how transmission rates go, how severe cases go, how hospitalizations go, and then kind of move from there. So again, I think Dr. Dillahay will probably have some more to say, but we don't know the answer, but it's not anytime in the very near future.
And one thing to add to that is we have to keep in mind that vaccines take time. It's not that you get the shot and you're protected from the first minute. Your immune system has to respond and develop immunity. And right now, both vaccines that are available are two-shot series. So it takes a couple of weeks after the second shot to be fully protected. So we can kind of think about, as Dr. Dillahay said, that unfortunately we're not getting the amount of vaccine in the state that we would all like. And that's not, we're not unique in that regards. Every location in the country has the same concern. But as we get more vaccine and get more people immunized and then get the second shot, and then we have an appropriate time for people to develop immunity, that's when we start seeing the level of protection. And what we should see with that is decreasing numbers, as Dr. Jefferson said, decreasing numbers of new cases, of people sick, in the hospital. And when we get to the point where the likelihood of a virus spreading between a person who has it and somebody who's susceptible is low enough that we can be confident, then we can consider, when do we take our foot off the gas? When do we start slowly backing down? And it's not going to be tomorrow everything is back to the way it was. It will be, I'm sure, gradual, sectors that reopen, few things that are either lifted or modified. And there may be some things that we're learning as we go through that are probably good ideas that we need to continue to carry forward. And so I think that people just need to really be measured in their expectations. I think we will get there, but it will take it will take some time.
Okay. We are coming up on 1:24, so I want to just quickly, if we can, I know there's a lot to be said, but I want to get to as many of these as possible. One person said, I'm allergic to bees. Will I be able to take the vaccine, any of them?
Yes. Bee allergy is not a contraindication to the vaccines.
Okay. Does the vaccine consist of MRC-5, aborted fetus cells? That's been a rumored ingredient.
The answer to that is no. There were some reports, misguided reports that asserted it, and it was not in either of these vaccines. So that is not a concern with either of the vaccines that are available.
Okay. If you have already had COVID, do you need to get the vaccine?
So, short answer is yes, you can get COVID again. There does seem to be some immunity that people may have after infection for 3 months, is what the CDC says. There's some data that may be a little bit longer than that, but you can get the virus again. And then the other thing to keep in mind, there are new varieties of the virus that are in other countries and now showing up in the US. There's some data out of the Novavax vaccine trial in South Africa that people were becoming infected with the new variant when they had it before. So that risk is there. And so after you recover, if it's your turn to do so, you should get the COVID vaccine.
I'm 68 years old and have type 2 diabetes. When will I be eligible? You know, and that's a good point. There are so many people who have underlying illnesses. Is there a way that they can, I hate to use the term cut through the line, but some of them really need to be able to cut through the line, because there are some people who may be in the age range to get the vaccine, but they're maybe not as not at risk as much as someone who has an underlying illness.
Well, we do know that the older we get, the higher risk we are, even without underlying illness. So it's not a fair comparison. But for people who have underlying illness or health conditions who are 16 through 64 years of age, can be vaccinated in phase 1C. Phase 1C also includes everyone who's 65 and older. So we would love to vaccinate them all now if we had the vaccine, but we don't have the vaccine. So we're having to be very careful on how we prioritize the groups.
So just going back to my notes here, phase 1C is estimated to start in April. By chance, could it start sooner?
By chance it could, but that chance would be that we would have to be receiving a lot more vaccines in Arkansas and have a lot more people in phase 1B vaccinated. I don't know if that will happen.
And I really want to throw out again, we touched on this, that some of the pharmacies, you can go there, even if you're not on the list, you can go there and get on their list. And if they have extra doses, for whatever reason, they may give you a call and you might be able to go in and get the vaccine. That is correct, right?
It depends on the pharmacy and how they've set it up. Some pharmacies already have long wait lists, and they just call the people on the wait list.
Okay. What about libraries? People are concerned about, people going in there and, picking up meals, using computers, connecting to the internet. I mean, doing all of these different things, and then these library workers are exposed. They can be exposed to an awful lot of people.
That is true, and they are being considered in these groups. We have not finalized the definitions, but they're definitely on the list to be considered.
Okay. I think I haven't gotten a note or anything from anyone or an alert, but I'm looking at the clock. It's 1:29, and I know you all have busy schedules as well. So I think what we're going to do then is we're going to start wrapping up. I'm going to give each of you 30 seconds. I don't have a stopwatch, so I'm not timing you. But I'll give you just a few minutes to give some closing remarks. If there's something that you want to share with our viewers that we didn't get a chance to talk about, we can start now. Dr. Vyas, why don't I start with you?
I think the main thing is to reiterate that the vaccines are safe. They are effective, all of them. They've been studied across populations, older individuals. They actually, each of the trials had a significant number of people of color. Each of the Pfizer and Mrna vaccine trials had at least 10% African-American participants, a similar number of Hispanic participants. The Johnson & Johnson trials were actually, I think, closer to 20% African-American or African, considering that they were done in South Africa as well. So they've been very well studied. And they are safe. And more than 25 million of our U.S. citizens have gotten it. without significant adverse events. So when it's your turn to do so, please consider getting it. And if you have any questions, reach out now. Any of us would be happy to help, as I'm sure your healthcare providers would be as well.
Okay, Dr. Dillahay?
Well, I would like to encourage people to do whatever they can to decrease the spread of COVID-19. We know that the more spread there is, the more likely that we are to get either imported variants of the virus, which could cause problems for us, or we could even develop our own homegrown variants. So it's really important to decrease the spread, and that would be by wearing masks, maintaining a good social distance, avoiding crowds, and also getting the vaccine when it's your turn to do so.
Okay. Dr. Jefferson.
I'm going to echo the fact of the matter with the data and the science behind these vaccines. So one, I just want to point out again, which has been stated, that in particular, the Pfizer and Mrna vaccines, the technologies used to produce those have been under development for 30 plus years. So these are not new vaccines, new completely things that were started just a year ago, which I think a lot of people think. We were able to modify them for this particular virus, but the backbone, the groundwork had already been done for a very long time. Secondarily, they are extraordinarily safe and extraordinarily efficacious. And, to really get ourselves out of this pandemic, vaccination is going to be key. The last thing I'll mention is that, as time goes on, we need to really, I mentioned that I'm all about health disparities and looking into that and figuring out ways to make sure communities of color are included and are safe. These vaccines have been studied, as Dr. Valles mentioned, in African-American communities and Latino communities, indigenous communities. They're safe and effective in those particular communities. And so if the vaccine is available to you, when it is available to you, I hope that you all consider taking it and taking it sooner rather than later. So not waiting for the next one or the next one or the next one. Every day people are being infected. And I know you're going to cut me off, Donna. Every day, people aren't just dying, but you have long-term consequences from the infection, long-term lung disease, long-term heart disease. They have long hauler symptoms. And so the real idea is to not become infected and to prevent that. And vaccines are the best way to do so.
You bring up an important point because, yesterday on FOX16 News at 9, we did a story on an African-American police officer who died from COVID. Obviously, this is a virus that does not discriminate, but it has hit the African-American community pretty hard. 71%, looking at the statistic here, 71% of African Americans know someone who's been hospitalized or died because of COVID-19, but still many Black Americans stand out as one of the groups that are less likely to take the vaccine. Dr. Greenfield, I want to end with you, but I just got a real important question from Dr. Gloria Richard Davis. She wanted us to address when ministers will get vaccinated because, they're dealing with the public all the time. So, Dr. Greenfield, I don't want to take away from your closing remarks, but if someone wants to address when will ministers get the vaccine, plus they're also great examples for their congregations. If they take the vaccine and, they do well with it, which they're likely to, more of their congregations will want to follow suit. They'll be encouraged to do so. So are they on the list?
So let me just say we're working to finalize our list. They are definitely on our radar screen.
They're on the radar. Okay. All right. Dr. Davis, you heard that. All right. Dr. Greenfield, I am going to end with you. Can you share some closing remarks, your thoughts?
Sure. To get through this, the vaccines alone are not going to be the key. Vaccination will be the key. So anything we can do to increase vaccination uptake, we strongly encourage. And I think that will include those folks who are particularly vulnerable, who don't have access to things like the internet, who are not on this call, who are not on Zoom, who are not on tech, who don't get this information, but in fact may qualify and may need help and assistance. So I encourage us, even if it's not your time, you may know someone who needs to get the vaccine and they may need assistance in navigating the system, how to get online, how to contact the pharmacy, to do these things. So I think, one, the take home that I would say is that please take the vaccination. And number two, please be a good neighbor and assist those who need it and who need access to help with accessing it. And I'll end there.
That is such a good point, and thank you. That's a great way to end. I want to thank you, physicians, for being with us for this very important town hall, and I want to thank all of the people who sent in questions. I know I couldn't get to every single one. We just didn't have time to get to all of them, but thank you. I tried to get to as many as we possibly could. They were all very good questions. But we are going to end this portion of the town hall, but stay put, everyone, not you physicians. I know you have to get back to work, as do I. But we are going to have a video, which comes from the CDC, that's going to give you even more information about the vaccine. So on that note, I am Donna Terrell. Thank you so much for joining us for this very important town hall. Good luck, everybody, and stay safe. Thank you, everyone.